Good morning. Today it's my pleasure to introduce Dr. Gopi Patel. Some of you will remember last spring when New York City was the epicenter of the global epidemic. Dr. Gopi and, Dr. Patel and other distinguished panelists spoke to us about what we knew about coronavirus at that time. And we're privileged now, almost a year later, to have her back at today's Grand Rounds to give us an update. Dr. Patel is the hospital epidemiologist for the Mount Sinai Hospital. She's also the medical director of the Mount Sinai Antimicrobial Stewardship Program. She is associate professor of infectious disease at Icahn School of Medicine, and she's played a major role in Mount Sinai's COVID-19 response. So thank you, Dr. Patel, for being here. We're very happy to have you join us this morning.
Just before you start, Dr. Patel, I just wanted to add just a few words. So cardiology was at the forefront at the COVID response, and I think, what we got to see was every day Gopi Patel was the face of the COVID resistance. It was a very arduous time, stressful time for everyone, and I think it was extraordinary that I would see her almost every day plotting and planning with Rupi in the leadership of the critical care unit, which was the center of COVID illness. And she was just extraordinary by her leadership, her calmness during the storm. And we've seen it even during the hectic rollout of the vaccine. She was kind enough to remember cardiology in the forefront and put us up in the front of the line, and the fellows felt quite reassured, compensated for the time and effort that they put in. And now, as we're hopefully leaving this COVID-19-21 period, and hopefully there won't be a 21-22, I'm sure she'll be at the forefront of preventing another pandemic here at Sinai. So again, with gratitude on behalf of everyone for the tremendous role you played in getting us through this very difficult time, I want to thank you very much and welcome to Grand Rounds. Thank you, Gopi.
Thank you for having me, and thank you for that really kind introduction. So I'm happy to talk a little bit about where we are, and I do want to note this is probably up to date as of 10 p.m. last night, and I'm sure something will come across with a tweet or a Instagram update or a New York Times update while we're speaking this morning. So I have nothing to disclose. And I'm just going to focus on the following: epidemiology, where we are now, any updates in prevention. I'll talk a little bit about vaccines and a little bit about the hectic rollout, and we'll talk about variants. So epidemiology. I don't know if most of you know, but today is a one-year anniversary for this institution and for New York City. A year ago, on March 1st, it was announced that the first confirmed case was detected in New York City. It was a traveler from Iran, and actually they visited our emergency department on February 29th, where colleagues diagnosed this traveler. In the background, New York State couldn't test. And we know early on this pandemic, there was really a failure to be able to test. Every isolate had to be approved by the CDC and then sent through local and state laboratories to get there. And on February 29th at about noon was when it was announced Wadsworth upstate could test for COVID-19. And it wasn't until later that week that New York City's public health lab could test. And what we know now through a lot of elegant work by a group of scientists here at the Mount Sinai Hospital and the Icahn School of Medicine is through looking at nasopharyngeal swabs tested for other respiratory viruses, flu, RSV, your normal winter cold viruses. When looking at those samples that were submitted from January to the first weeks of March, it looked like incomplete genomes of the SARS-CoV-2 virus were detected in samples from about mid-January to early March. And we were able to detect, and this is really through the work of Florian Kramer, Harm van Bakel, and Viviana Simon, that they were able to detect multiple independent introductions, mainly from Europe. Remember, we were looking at China at the time, and it wasn't until mid-March that any travel restrictions had been put on Europe. Multiple introductions of SARS-CoV-2 starting in late January and then increasing that last week of February, so the week ending in February 29th, to about 5% of samples and whole genomes being retrieved. Through a lot of work through Florian Kramer and Viviana Simon's lab and our microbiology laboratory, seroprevalence studies demonstrated by the end of May, the seroprevalence, meaning the number of individuals that may not have been confirmed with a diagnostic test, but were confirmed with antibody and specific antibodies, was about 20% here in New York City by the end of May. So where are we today? So all of us remember this initial surge that we experienced last spring. And again, it's our year anniversary. In-house, we were not able to test for COVID-19 or SARS-CoV-2 until mid-March. So March 15th is when we launched our first diagnostic testing platform. We didn't close schools here in New York City till March 16th. New York went on pause on March 22nd, and mask mandates didn't go into effect citywide until April 1st, although here at the Mount Sinai Hospital, we recommended universal masking around March 17th. And I think you can see what occurred, and many of you experienced it. We plateaued in terms of hospitalizations and case numbers this last week of March and the first weeks of April. And over time, with a lot of public health measures in place and a lot of compliance with those public health measures, we actually started to see a very nice summer and coming off that curve, or the flattening of the curve. What we didn't know what would happen is toward the end of the summer, whether it was complacency, the weather was still nice, but I think it was a lot of holidays and people starting to get together, that we started to see an increase in the number of cases, not just in New York City, but also within the country. Please note that I think all of us, as we were experiencing a better summer, a lot of places were surging in the United States. So I think one of the questions was asked, is this two different waves? I think it's just two different surges within one large wave. That's my opinion. Many public health authorities think differently. So starting Labor Day, we started to see an increase in cases, and note that because the incubation period is about 14 days, you could see a doubling of cases around 3 incubation periods later. So that's kind of what we saw. So Labor Day, then Halloween, Thanksgiving, then Christmas. And I think any of you who were here over the last few weeks noted it was a really rough winter here at the hospital, although not as severe an illness as what we saw in the spring, because people were coming to care a little bit earlier than what we saw. We had testing in place, and widespread testing at that. So during the summer, when they were looking at other centers in the United States, we learned a lot of things. And for those of you who've been watching indoor dining, this is kind of the data that sort of drove why New York State and New York City did what they did. So drivers of community acquisition, and you can see some community activities that I think a lot of us take for granted. So shopping, going to restaurants, the office setting, hair salons, being at home with a large group of people and being at home with a smaller group of people, the gyms, public transportation, bars, coffee shops, and church and religious gatherings. And if you look at this from July, you can see restaurants, specifically indoor dining, even if it's an intimate setting with only a few people, was really a driver of community exposure. So as we're opening up indoor dining here in New York City, you can see why this is something that everyone is watching very closely. So I think we always think about this, who's in your bubble. And I think as we're all getting vaccinated, we're sort of thinking about how does this bubble change, or who's starting to become part of our bubble. And I think this is something we all realize, that you don't know how small or how big your bubble really is. So if you have kids in school, what are the other kids in school doing? What are those parents doing? What's the babysitter doing? What are the teachers doing? So our bubbles are larger than we think. And this is from New York State in December. And I think this also proves a point. If you look at the most likely drivers or sources of exposure in New York City and New York State in September through November. So those gatherings we were talking about, so definitely a driver here in New York City. And then the second most common was healthcare deliveries. So that's hospitals, urgent cares, clinics. We were starting to see exposures in healthcare. So where are we now? So as I said, the hospitalizations, we're not nearly seeing the surge that we saw last spring, but we did see a significant surge. We definitely saw difficulties in maintaining capacity, especially procedural capacity. I think we had 3 fully staffed and fully occupied wards here at the Mount Sinai Hospital, peaking at about 119 to 120 cases in-house during this second surge, and we're still in the 100 hospitalization zone. But I wanted everybody to heed this, and this is kind of a nice pictorial. So this is from the CDC as of yesterday. These are daily case trends. You can see sort of what happened across the country and this very large fall winter spike that we're kind of stuck. So you're not seeing it come down, and we're still north of 70,000 cases a day. So we're clearly not out of the woods. And if you look at that, that's the peak that was seen over the summer in the United States. So I'm going to move on to prevention. And I think we've learned a lot. I think if you were talking to me this time last year, we recommended not wearing masks. Of course, that changed on March 17th. And we're going to talk where we are today. So we learned a lot. We learned that an individual who is asymptomatic can spread disease through respiratory droplets and small aerosols to another individual. And so masking was not only helpful for that individual who wanted to be protected, but also the individual to keep those droplets in. The whole idea, I mask up for you, you mask up for me. We also noted the importance of physical distancing, and for every meter away, and so this is from the Lancet, so meters rather than feet, but for every meter away, the more protection one had. So really that social distancing 6 feet apart, especially when you can't wear a mask, and even when you are wearing a mask. So this has been in the news lately based on a study that was published in the MMWR. So not only are we asking everybody to mask up for themselves and for others, but now there's questions about double masking and what's called the knot and tuck. And any of you who can do that with a surgical mask and get it to fit properly, that will be quite a feat. So most of you have noticed cloth masks don't fit completely perfectly unless you found that one that's perfect for you. There's often gaps at the side or under your chin. And same thing with our surgical or procedural masks. So what the CDC did is they did a simulation study using head forms in a poorly ventilated space that were 6 feet apart. And they used 10 different configurations of masks, including medical masks, cloth masks, and then those combinations of the two, and what's called the knot and tuck, and you can Google it, medical procedural mask. And what they did is they simulated a cough. They simulated a cough, and we'll talk about the source, which is the person with the cough and with COVID, and then the receiver, who's the individual who's trying to protect themselves from the source. And you can see with the different configurations, the highest protection was mask to mask, and specifically this idea of a double mask or a knot and tucked procedural mask. And what that is a surgical mask where the fit is improved by putting a cloth mask on top and having multiple layers of filtration. The knot and tuck is same thing. It's your 3-ply surgical mask with a knot of both ear loops and then a good fit around the nose, chin, and cheeks. And that also gave up to 80 to 90% protection of the receiver. I think though, in my mind, still the most important thing is to wear a mask and just be cognizant of who you're around and who you're with and how well that mask fit. I think all of us sort of walk around New York City or even walk around outside the hospital and note that there could be improvement in just wearing the mask, that it's covering your nose, covering, fitting your chin, and not being worn as a chin strap or some kind of like an earring around your ear. So that moves me to vaccines, which is something that's really exciting, and who knew that we would be here a year ago. So this is a map from yesterday of the United States and vaccine coverage. As of yesterday, or sorry, this is Saturday, 72 million vaccine doses have been administered in the United States, with about 24 million individuals receiving the second dose, which is about 9.3% of the adult population. And I think Dr. Goldman referred to vaccine rollouts as hectic. I think we've had a lot of trip bumps and falls here in the United States in terms of vaccine rollout. And you can see how every state is a little bit different in terms of their vaccine coverage. This is adult vaccine coverage. In terms of the adult population in the state, every state has a different sort of rollout plan, although every state started with healthcare workers and nursing home residents. What happened after that sort of changed. Some states are still at 75 plus. Some states like our own are at 65 plus, and those with comorbid conditions. But you can see it's been very variable across the United States. And there's a lot of high hopes for sort of a solidified a nationwide plan in terms of vaccination. It's very interesting, however, we were always concerned about rural areas being able to vaccinate well and vaccinate a large number of patients. And if you look, places that are considered rural have done a really great job. South Dakota, New Mexico, including the Indian Health Reservations and the Indian Health Service, and Alaska actually have some of our highest vaccination rates. And I think many people have heard about the success in West Virginia. So I'm not going to spend a lot of time talking about mRNA vaccines in terms of how they work. I think many of you know that from the numerous town halls that we've had and just from reviews of the literature. We will talk about the Janssen vaccine a little bit, and we're very excited that it received the EUA on Saturday. But if you could look at the technology and the number of doses, you can see the vaccine efficacy for Pfizer and Moderna for mild to moderate disease was upwards of 90%. And I think no one ever thought that would happen, and we might be victims of our own success. That is unbelievable, and it's really only shared by the measles vaccine in terms of efficacy. The protection from severe disease, and that's based on sort of what the CDC and WHO consider severe disease, is upwards of 80% for all three vaccines. And I think it's really important to remember the Janssen vaccine was studied both in Brazil and South Africa, where variants of concern were circulating, and also studied in a period of time where we had high transmission rates. Remember, Moderna and Pfizer were, those trials initiated in March and April. So with the initial, we'll call it the D614G variant as being the predominant variant across the world. So these vaccines have not necessarily been studied where these variants of concerns are circulating, which is different from the Janssen vaccine. I think it's really important to remember that these are really good at preventing severe disease and hospitalization, which really is the goal of any vaccine, much better than the flu vaccine that we use every year. And this is the ultimate goal that they were setting out, to prevent the severe and COVID-19 related hospitalizations and deaths. So as I said, the Janssen vaccine, which is a single dose adenovirus vector DNA vaccine, was received the emergency use authorization from the FDA on Saturday. And that was based on the Ensemble trial, which included 43,000 participants and had 468 cases of COVID. And I think that's really important, again, to highlight that there was a lot of COVID circulating. So they did have a lot of cases to compare the placebo and vaccine recipient arms. The reason this vaccine is considered a game changer is it's a traditional vaccine in the sense that it's a single dose vaccine and refrigerator stable. It can be stored in a refrigerator for 3 months. And that is considered the best option by the WHO in a pandemic setting to allow for increased access, distribution, and compliance. It has been really difficult for a lot of institutions and a lot of places, including our own, to make sure someone appears for their second dose of vaccine in a timely fashion. And here's some data from the EUA documents that are available online. What the efficacy was 14 days after vaccination and 28 days after vaccination in the US, Brazil, and South Africa. And again, in South Africa and Brazil, both variants of concern that have been associated with those areas. So the B1351 in South Africa and the P1 in Brazil were circulating. And so you can see the moderate to severe. This is where in South Africa it was about 64%, in Brazil 68%, and in the US that's where we get the 72% effective after 28 days post-vaccination. And then if you look at critical disease, the efficacy is much higher. And it looks like over time, if you look into the FDA documents that were submitted, over time efficacy increased. So by day 49, there were no cases in either arm in the vaccine arm in this trial, and it's still ongoing. So with all of this, there have been some vaccine controversies or proposed strategies in improving vaccine coverage. And number one was the delay of the second dose. Many of you know early on when there was limited vaccine supply, there were strategies discussed that instead of holding the second dose, that we should just give all doses that are available and allow for a slight delay, whether it be a week or so, of the second dose, based on the studies where it demonstrated a divergence between the cases in the placebo arm and the vaccinated arm around day 10 to 14 post first dose. This would really help with vaccine coverage, but really with everything I've sort of spoken about so far, there have been so many missteps in messaging, and we have a trust deficit, that to say that to a group of individuals that are so focused on getting vaccinated or may not hear the message the way that we want to message it, we may lead to a lot of individuals missing that second dose, either electing not to take it or just missing it based on delays. So there's a lot of schools of thought out there. I personally think we should stick to what was studied and follow the vaccine schedule, with the only delay being for one, you got COVID, or two, things like you don't have supply because of snowstorms and the rest. There's also a lot of data coming out from Dr. Kramer and Dr. Simon's group, as well as others, that based on someone's serologic status, perhaps they have a robust immune response with a single dose of vaccine. And I'll show you some of that information in a subsequent slide. So in terms of real world vaccine effectiveness, we can look to Israel. So Israel has vaccinated to date about 40% of the population. I don't want to get into politics, but that's the Israeli population proper. And about 50+% have received at least one dose of vaccine. So a huge mass vaccination campaign, and fairly successful. So we're getting a lot of data out of Israel currently. And the Ministry of Health has partnered with Pfizer, BioNTech to provide a lot of this information. So this is from the New England Journal from about a week or so ago, where they looked at 5 outcomes: documented infection, symptomatic infection, hospitalizations, severe COVID, and deaths due to COVID. And I think you could just visually see, if day 0 is the first dose of vaccine, that over time, a nice divergence, the unvaccinated in red and the vaccinated in blue, and a leveling off of cumulative incidence. So based on this, the vaccine effectiveness estimate, so this is real world, which we like the phase 4 of these trials, like to look at, is 14 to 20 days after the first dose. It appears to be 46% effective, and this is the Pfizer BioNTech vaccine. 21 to 27 days after the first dose, about 60% effective. 7 days after the second dose, 92% effective. They also, and like the US, doing lots of studies amongst healthcare workers, a very captive audience, the vaccine efficacy appears to be high, about 89 to 91%, days 15 to 28 days after dose 1. But remember, this is a very captive audience, the healthcare workers, so might not be reflective of the larger population. The other thing to say about Israel is they did their vaccine rollout very differently than we have. They have really stuck to age. So in patients or persons 60 years and older, they have an 80% vaccine coverage rate. They also were able to leverage, just based on their infrastructure and their frequency of having to deal with events of concern where they had to mass distribute or mass attend to lots of people, they were able to step up vaccination efforts very quickly and in a very organized manner, as opposed to other countries that have continued to struggle. And I think one thing we can get from this also, and this is also from the Israeli Health Ministry and Pfizer-BioNTech, is that there is a decrease in asymptomatic infection. And even though this was not the point of the clinical trials, it does make sense that we would see less asymptomatic transmissions and asymptomatic infections with vaccination. In the SIREN study, which is very similar to the Paris study that's happening here at Mount Sinai through the school, the SIREN study is a prospective cohort at sort of through the NHS in the UK, looking at UK healthcare workers with a really high vaccination coverage rate, about 89%, where they test them for asymptomatic infection twice a month and screen periodically for antibody titers. They did demonstrate a decrease in asymptomatic cases in addition to symptomatic cases with sort of surveillance of staff. The B1.17 variant is predominant during this study, and this is the SIREN study published in the Lancet, and 72% vaccine efficacy was noted 21 days after the first dose. And remember, the UK is delaying the second dose for both the Pfizer and the AstraZeneca vaccines, and 86% 7 days after the second dose. And then in terms of what I was describing about single doses in seropositive individuals, this is from Dr. Kramer's laboratory and includes members of the Paris study, which are mostly healthcare workers. So they did a pre-assessment of antibody titers specifically to the spike antibody. This is not the test that we have available to all of us. This is a lab test that they are using. But you can see in the seropositive individuals, so 41 of them, that's the orange, and the blue, seronegative, what the vaccine response or the antibody titers were days after the first vaccine dose. So 0 to 4, 5 to 8, 9 to 12, so on and so forth, and post the second vaccine dose. And you see this robust antibody response in those who were seropositive for COVID-19, anywhere between 5 to 8 days post-vaccine dose, and sort of it stays there. And we're talking logarithmic, robust vaccine response and antibody response, really questioning whether these individuals, get that second or third boost with the first dose, whether or not they really do need a second dose. Now, this would require everybody getting a very sensitive antibody test prior to vaccination, which would be another difficult thing to manage. But this data has borne out in other studies out of the UK as well as Israel. I think the other thing to remember is immune responses are multifaceted. So they don't just include antibodies, but also include cell-mediated immunity. So CD4 cells, CD8 cells, IgA, IgG, and memory B cells. And there is more data about native infection and the durability of immunity. This is a beautiful paper from Science that really sort of brought me back to medical school and relearning my immunology, but noted that over time, things change. That primary adaptive immune response, the predominant pieces or parts of that immune response are slightly different. So you can see that IgG decreases or stabilizes, that you see your CD4 T cells and CD8 T cells sort of changing in predominance. So really that T cell mediated immunity seems to be a big factor in controlling infection and controlling and preventing reinfection, which might be some of the reason we tell you, please don't check your antibody tests after getting vaccinated. So antibody tests are for a specific purpose. They help with serosurveillance to see who may have been infected and will tell us about past infection, but vaccine effectiveness doesn't necessarily correlate with antibody titer. Those of you who've taken any vaccine and then had your antibody tests checked sort of, and then were prompted to get another or a booster dose, know that this is not necessarily the case, that those titers change over time, but you're still protected. I like to think of myself an example. I have, being an ID physician, I'm exposed to shingles or varicella pretty much weekly. And I have never mounted a response to the varicella vaccine, but I've never gotten chickenpox after all of those inadvertent exposures. So likely am protected and have refused now to take a 5th booster for varicella. And I think we see this with Hep B, we see this with measles. We saw a lot of individuals who've been vaccinated with measles who had titers in 2019, which was the last outbreak in New York City we were dealing with, that didn't mount titers, but were still well protected. Not everyone will have a positive test. It really depends on the test used. Do they go for the spike antibody or the nucleocapsid antibody, which, remember, vaccines encode for the spike protein, all of them that are in advanced clinical trials. We also don't know what cutoff is considered effective. And hopefully I've demonstrated to you that there's more than antibodies involved in the immune response. And it's really difficult to look at T-cell activity in a timely fashion. So in terms of, just to sort of hammer it home, all of these EUA vaccines have been noted to have fairly strong T-cell mediated responses. And you can find it deep in that phase 1 and phase 2 trial data that's out there. And again, if you look at that T-cell response, it does probably influence vaccine efficacy and the protection from severe disease, hospitalization, and death. I think, though, if you're looking at the news, you'll see some press about these other vaccines. Novavax and AstraZeneca are in advanced clinical trials. I'm not going to talk about Sputnik 5 or Sputnik V, however you'd like to say it, although you know that that's being used in Russia for vaccination. It's also being used in some South American countries or Latin American countries. Novavax has a interesting technology. It's an adjuvanted spike protein. It's a 2-dose vaccine. It was studied in South Africa, and it's 89.3% effective in the UK, 60% effective in South Africa. And the PREVENT trial is occurring in the United States and Mexico with the goal of enrolling 16,000 individuals. So that trial is ongoing. Again, preliminary data suggests really great protection from severe disease and protection from hospitalization. AstraZeneca is a replication deficient chimpanzee adeno5 virus vector. It's also a 2-dose series. It's about 70% effective, and the South African trial was halted. And I'll talk about that data when we talk about variants in this subsequent slides. Also 100% protective of severe disease and protects from hospitalization. This is courtesy of my daughter, who's 7 years old and has missed her entire sort of year and is accelerated in growth. But really what everybody wonders about, I think, is when can we sort of have our kids have a normal childhood and go to school without masks and play soccer and go to dance and please go to summer camp. And just so you know, I think some of you have asked me, in terms of the mRNA vaccine, both Moderna and Pfizer are currently evaluating a vaccine safety and efficacy in children 12 to 15. Remember, Pfizer is EUA approved for 16 and up, Moderna for 18 and up. So the Moderna trial is ages 12 to 18. And usually over time, we de-escalate in age. So the next goal will be ages 9 through 12. Unfortunately, none of these trials are available in New York City and New York State. None of our institutions are embarking in the adolescent trials. However, many children's hospitals are, and the thought is we will have data by the end of the summer and early fall. In terms of herd immunity estimates, this is based on the replication number. This is sort of a crude estimate, but to give you an idea where these numbers are coming from that you hear in the news. When everybody is susceptible, the replication number, or the R0, is high, so you need a very high vaccination rate. And circulating variants increase the R0 because there's increased transmission, meaning more people are infected if the source has a variant. And this is why premature relaxing of restrictions and that daily case volume incidence of 70,000 new cases a day, it's really high, although lower than previous weeks. And just to give you an idea of where we are, seasonal influenza is about 1 to 2, the replication number, and through vaccination, we can make it lower. And the herd immunity estimate's about 35%. Measles, highest replication number are not. We talk about one person being able to infect 14 to 17 people without vaccination. So that herd immunity estimates that 95%. And we saw that in the spring of 2019. For SARS-CoV-2, we've seen numbers from 2 to 3. And we can look at the UK variant of what happened in the UK, where the R naught with restrictions was about 0.4 to 0.7, and then rose up with the circulation of the UK variant to 1.4 to 1.8. And so that herd immunity estimates about 60 to 70%. That is with no variants and everybody doing the same thing and all of us getting vaccinated and using that previous sort of immunity or seroprevalence to help us get to the 60 to 70% number. So as I sort of said, to achieve 70% vaccination rate at the current pace will take over a year. Now we know there's 28 million laboratory confirmed cases in the United States as of yesterday, and through serosurveillance, it's estimated 70 to 90 million Americans were actually infected. 27 million patients have received their second dose, but there are overlaps. So some individuals who had COVID definitely have gotten 2 doses of vaccine. So you can see, unless we increase our vaccination rate to about 3 million persons a day, we're not going to be at the place we want to be with variants circulating and without those restrictions until later this year. So we've got some work to do. And I think this is something we really do need to sort of focus on, and I need actually all of your help here, is vaccine skepticism. It's super complex, very multifaceted. This was a highly politicized vaccine. We used a lot of scary language, Operation Warp Speed, who's going to get there first. And I think the difficulties in access, sort of using online platforms to schedule appointments, the difficulties even here and making sure we had a smooth rollout have actually turned a lot of people off or sort of accelerated or made those concerns about elitism, this sort of being elitist, much more clear and very difficult to combat. It goes back to that trust deficit that we have from mixed messaging and from populations that were disproportionately affected by COVID. And let's be honest, there's some structural racism in healthcare that we're really trying to address, and we need time to address it. These individuals are not anti-vaxxers, right? Those are 1 to 2% of the population that you're not going to convince them through logic or science to get vaccinated. These individuals get vaccinated or their children get vaccinated. It's really a concern about safety. Was this too fast? And they weigh the risk of acquisition for COVID and the perceived risk of the vaccine. Now, in those trials for Moderna and Pfizer, we're talking about 40,000 recipients of vaccine, and now we're at 78 million Americans receiving vaccine. So that safety data is out there, and the risks of those safety concerns have not been founded in this real world data. We have seen here at Mount Sinai Hospital and throughout the school that employment in healthcare does not preclude skepticism. And a lot of us were a little skeptical as we wanted to see the data, just as the FDA advisory committee was seeing the data. And a lot of individuals took the wait and see approach. They waited till their colleagues got 2 doses. They wanted to see that everybody did okay. And we had to be very frank about the side effects. Your arm will hurt. You might feel crummy the next day. Even if you feel crummy with the first dose, please, please, please come and get your second dose, because you need that second dose to get the T-cell immune response. And that was seen in those phase 1 studies. And we've missed these opportunities to explore the deep-rooted mistrust. So I think someone said this, and I thought it was really well said. People need confidence in the vaccine, the vaccinator, and the health system offering the vaccine. But I do want to offer some optimism. So we're moving from skepticism to optimism, that if you do get vaccinated and the people around you are vaccinated, you can alter your behavior a little bit. So remember, your behavior in private and your behavior in public are very different. And you can have sort of lower risk interactions between vaccinated individuals. I don't know about you, but my parents have been waiting in California to get their second dose of vaccine. And once they are vaccinated and it's 2 weeks later, I plan to finally see them after a year. I'll have had my vaccine in 2 doses and 2 weeks out, and they'll have their vaccine. And I don't have to stand, which is what I make my brother do, stand in the backyard and talk to them through a screen door. I can come in the house, I can hug them, we can have dinner, and that would be a lower risk interaction. But think about who you are and where you're at. So if you're outdoors and you're 6 feet apart and you're with other vaccinated individuals, that's probably a safer event. If you're at the grocery store and you know nothing about the people around you and what their health condition is and whether they've been offered vaccine, that's probably not the time to take down your mask or act differently. So I think there is some optimism out there. We still have to emulate the best behaviors and those non-pharmaceutical interventions, so appropriate masking and distancing in the workplace and in public. I'm not advocating for an immunity passport because, again, that demonstrates the haves and have-nots, but I do think there is some optimism out there, provided we are able to vaccinate more individuals. So now variants of concern, and I'm going to try my best to refer to the variants by their number designation rather than the areas where they're dominant, but I'm sure I'll slip here and there. So why are we concerned? These variants offer efficient transmission and can invade the immune response. So we know that neutralizing antibodies target the spike protein and prevent attachment to the ACE2 receptor. And so if you have mutations in specifically the receptor binding domain of the spike protein, you can alter that interaction between the ACE2 receptor and the virus. And so you see increased transmission. So these variants, usually with mutations in that receptor binding domain, can increase the viral load, increase the affinity to the ACE2 receptor, and thereby increasing transmission. There's also alterations in that RBD that can change the conformation of the spike protein and therefore block antibody binding sites or make new antibody binding sites, therefore evading specifically monoclonal antibody-mediated immunity. So what we've seen is an accumulation of many key mutations. So mutations accumulate about 1 to 2 single nucleotide mutations in a month. Coronavirus is sort of a novel RNA virus in the sense that it does have a proofreading enzyme. So this mutation rate is a lot lower. So it's about half the rate of flu and about a quarter of the rate for HIV. The S protein, which is that spike protein, is about 1,273 amino acids. And the receptor binding domain, which is the domain we're most worried about, is amino acids 319 to 514. So if you ever hear a number between those numbers, that's what we're concerned about. So as I said, in early March, we saw the D614G. That was the most predominant sort of mutation that we saw from the original Wuhan virus that dominated what we saw in the spring and summer here in the United States and all over the world. In about September and more dominant in the UK, the B117 variant came to be. And what they noticed in the UK is that even with social distancing in place, they were still seeing high transmission rates. And the mutation of concern, which I'll talk about on the next slide, is this N501Y mutation. And that's specific, or that was the first time that they saw a large number of viruses circulating with that particular mutation. Just so you know, however, the UK has done an amazing job doing genomic surveillance. They do whole genome sequencing about 5 to 10% of all circulating virus. So they're very much ahead of us in terms of doing that. They are also the group that then recognized this, what we're calling the B1351 variant, which is dominant in South Africa, that has 2 additional mutations. So the K417N, the E484K, and the N501Y. So that same N501Y. And then in Japan, discovered in travelers from Brazil, is the P1 variant that has the same sort of variation at the K417 spot and the change there, E484K and 501Y. These are some important substitutions. There's also deletions that change sort of the conformation of the spike protein and the ability to bind to the ACE2 receptor. So this is as of Saturday, we've seen increased prevalence of the B117 in the United States and handfuls of cases of the B1351 and P1. So as I said, for the UK or the B117 variant, there's mutations in the spike protein, specifically this N501Y, and models suggest that at the current rate of transmission that the B117 will be the dominant variant in the United States by the end of March. As I said, in the UK, they detected this in September and it became the dominant strain in December. There was no appreciable impact on vaccine efficacy or the efficacy of monoclonal antibody therapies. So that's emergency use, bamlanivimab or casirivimab and demnivab, and no evidence of increased pathogenicity. And as of February 17th, 59 cases of the B117 were detected in New York City. If you look that week, the week prior, so the week of February 8th, it was 6.2% of submitted isolates, and models do suggest even in New York City that this will become a dominant strain. So let's talk about the E484K mutation. It's an escape mutation. It's found in the B1351, P1, and P2 variants, and there has been evidence of increasing prevalence and incidence amongst the B117 variant in the UK. What's really concerning about this mutation is it affects neutralization efficiency of the monoclonal antibodies, as well as antibodies found in convalescent sera, especially those individuals who are infected early in the pandemic, and casirivimab, which is one of the monoclonals in the casirivimab, indemnivab, or Regeneron product, and bamlanivimab actually do not neutralize virus with the E484K. And I think those of us who see patients who've received these monoclonals in the outpatient setting or the ambulatory setting are wondering if this escape mutation is actually more prevalent, and our genomics colleagues are looking for it. And I think we're really concerned about what's referred to as the South African variant or the B1351 variant. So I talked about the mutations. It's been identified in samples from South Africa dating back to October, and it's a predominant variant in South Africa. There's no evidence of increased pathogenicity, but it is able to escape neutralization from antibodies in the plasma of previously infected patients. And there's a 6 to 8-fold reduction in the neutralization of these strains from both available mRNA vaccines. So they took sera from individuals who received both doses of Moderna and Pfizer and noted a 6 to 8-fold reduction in neutralization. Remember, those antibody responses are so profound, so it's unclear whether it really affects vaccine efficacy, but that is a fear that many individuals have, that if this continues to be the circulating variant, that we'll need either a booster dose or a multivalent vaccine in the future. These are also resistant because of that E484K to the monoclonal antibodies that we have available. So casirivimab and bamlanivimab, just so you know, the combination Lilly monoclonal, so bamlanivimab, etesivimab, it doesn't look like there's resistance to etesivimab. And remember, casirivimab is part of a combination monoclonal, and it doesn't look like there's resistance to indemnivab. But in general, then, instead of giving a polyclonal antibody therapy, you're giving a single monoclonal antibody therapy. So resistance through another mutation is always possible. What's interesting is both Novavax and AstraZeneca have also been studied in South Africa. And I think this is super interesting for Novavax, that a third of study participants were seropositive at the time of enrollment, and they noted no difference in infection rate among seropositive and seronegative participants in the placebo arm. So about a 3.9% infection rate amongst those individuals in the placebo arm. That implies that prior infection, at least in South Africa, where there's really a high rate of prior infection, was not protective. So there may have been reinfections, so 3.9% reinfection rate. And then AstraZeneca, obviously roll out many of you know this, but AstraZeneca, the vaccine was considered not effective for mild and moderate disease in South Africa. So it's not being offered in that country at this time. So the P1 contains that N501Y, E484K, and the K417T. It was first described in a family arriving in Japan from northern Brazil in early January 2021, and they had been visiting the Amazon area of northern Brazil, and they do screening at the airport. And because of their travel history, they did genomic sequencing and found this particular variant. One of the 4 individuals did end up being hospitalized for a very short period of time. And what has been noted now subsequently is increasing rates of reinfection, especially in that area of Brazil, which was hit hard. Probably 75% of the population had previously been infected with COVID, and now in late December, 42% of sequenced specimens have this P1 variant. And you can see here, this is all from sort of preprint, but reports of reinfection in northern Brazil. Many of you have heard about the California variant. It currently accounts for about 50% of cases in 44 counties in California. It does not have those 3 mutations that I was previously discussing. It does have the D614G, but it also has this L452R, which stabilizes the interaction between the ACE2 receptor and the spike protein. It appears to be less susceptible to convalescent sera and sera from mRNA vaccine recipients. And there's been some press about perhaps it being more pathogenic. This is coming from Dr. Chu's group at UCSF. I don't think it's available in preprint yet, so we'll see what the data actually shows, but it may be biased looking specifically at hospitalized patients at UCSF hospitals. But I think this is what we want to hear about, this B1526, which is now being called the New York variant. This data comes out of Caltech as well as Columbia. Our genomics colleagues are finding an increased incidence as well. But what Columbia has been doing is they have been doing PCR screening of positive samples, about 5 to 10% of samples, looking specifically for the N501Y and the E484K mutations. And what they found is over time, they saw an increased incidence of these E484K mutations that were not associated with previously described variants of concerns. So in their sort of surveillance, they found 6 B117, so that's the UK variant, 2 P2s, which are slightly different than the P1s, but of the same background as the P1 variant, 1 B1351, and they found 49 strains with the E484K that were of this separate lineage, the B1526. And what's really concerning is in vitro, these isolates, probably due to the E484K, evade neutralization by the commercially available monoclonal, specifically casirivimab and bamlanivimab. And there is a suggestion that this is becoming dominant because over time, it's about 12% of the isolates that they're evaluating. So what does this mean for vaccine? It means we might require a booster dose. Moderna has submitted a potential booster dose to the NIH from phase 1 trials. This might mean that Pfizer and Moderna will become multivalent vaccines in the future. So in that lipid particle, similar to what we do with flu vaccines, right? They're trivalent and now quadrivalent. In that lipid particle, they would put another mRNA. So they put the mRNA for the D614G and then an mRNA that covered 351. And Janssen is currently investigating a second dose, and we'll get that data hopefully by April. So in conclusion, I hope I left a few minutes for questions. We really need to enhance our genomic surveillance to be able to detect these variants sooner. And I think our genomics team here is contributing to that Herculean task. We do have to work together to increase vaccine coverage, not just here in New York and the United States, but globally. This is a global pandemic, and contribute to vaccine confidence. We need to continue to recommend the risk mitigation and non-pharmaceutical interventions, appropriate masking. I'll start with please wear a mask, and then in the right setting, consider using a better fitting mask. I personally like the ones with the filter in it, or just something that fits a little bit better, and increase surveillance testing. So many of you may have seen the New York Times article today about the decrease in the number of tests. Either people are not traveling, so a lot of people are getting tested prior to travel or from return to travel, whether there's less high-risk exposures, and you've seen some relaxing of guidance, and whether because of weather, people are not getting tested as much. But that increased sort of asymptomatic testing is also very important, especially if we don't have vaccine coverage, to keeping numbers down. So that's it.
Gopi, can you hear me?
I can hear you.
Excellent. That was phenomenal. You know, it was around a year ago you participated in one of our conferences, and that was a great update. You know, we're running short on time, but can you tell us from an infectious disease doctor, we're now seeing these long haulers, these patients who post-COVID are still having symptoms. Do you have any approach that you're adopting or recommending for treatment for those patients for such a diverse type of symptoms that they have?
So there's a lot of study about these long haulers or long COVID cases. For now, I'll be honest, I refer them to our COVID care clinic. It's set up downtown, and many of them also come here uptown to get care. And a lot of it's supportive. No one knows why this is, whether they had prolonged viral replication or if it's a dysfunction in the immune response. But it does look like it is a real entity, and there are a lot of factors, and not everyone presents the same. There's the cognitive issues, the physical issues, decreased lung capacity. It's all very different. So for right now, in an absence of data, I do tend to refer them to our post-COVID care clinic, and they do have really good feedback because they do address all of those issues. So I apologize. It's not clear that it's a remnant of the infection versus a remnant of the immune response to the infection.
Thank you very much. Any other questions?
I have a question, Dr. Goldman. Dr. Patel, it's Ben Beer, one of the fellows. When you mentioned that I think Moderna and Pfizer are both are going into phase 1 trials for kind of a covalent or a new variant update to their vaccine, the fact that we use different sequences for the flu vaccine, does that give us hope that the ability to update these already existing vaccines with new or covalent or triple valent vaccines, is that a shorter timeline than the development of the initial vaccine?
Absolutely. So they know that the delivery of the vaccine works, right? That nanoparticle, that lipid nanoparticle works. So as I said, Moderna has already submitted to the NIH for sort of abbreviated phase 1 trials to look at the, I think it's called the mRNA 1273.351 sort of lipid particle. So do phase 1, and then they're also looking at what we've talked about, like a covalent for the treatment naive. So those individuals who have not been vaccinated. The sera, it's still, if you look at the sera of those of us who have been vaccinated either with Pfizer or Moderna, it does still look like that the antibody titers are so high that there is still neutralization with sera. However, it's not as robust as with the wild type. So I think more to come, but it should be, these vaccines are safe. Yes, there are side effects in terms of sort of our reactogenicity to the vaccines, but I think it will be faster. And the great thing about mRNA technology, it's very easy to ramp up. The worst thing about mRNA technology, it's really hard to store and distribute, right? So I think it's going to be a sort of a catch-22, and it's unclear when the boosters will come. If we could stop transmission, we could stop mutation and variants. So that's why everything has to be done together in combination.
Thank you so much.
So the billion-dollar question, can you project a time in the future, whether it be 6 months, 8 months, a year, that we don't have to wear masks? Or do you think that masks are with us forever?
This is sort of a personal thing, I think. I'm hoping for us to see some light at the end of the tunnel, probably in the fall, but we do have a ways to go. I would not be surprised if we continue to wear masks in places like airports and airplanes. It's interesting. If you look at what happened in Australia, those of you who watch tennis in the Australian Open, they, through lockdowns, et cetera, they were able to have the Australian Open with, people not wearing masks, but immediately locked down because of what was happening in the community, and revoked that. So I think we still have a ways to go. And again, this is a global pandemic, so we sort of have to look at what's happening around us. And so this vaccine effort can't just be in the US alone. We really have to work with our partners globally to vaccinate everyone. and prevent continued spread of variants. So I'd like to think the fall will see some difference. The summer might be just as nice, but we don't want to see that uptick that we started to see in the early fall, this coming fall, and then we'll have a better idea when the masks can come down with some permanence.
So if those people who do can reach Gopi Patel on the hospital interoffice email, I just want to thank her very much again for her leadership and a phenomenal presentation. And I'm hoping that 1 year from now, you can look back and say it's gone, we don't have it anymore, and everyone can see each other's smiles. So again, thank you very much for everything you've done and continue to do on a daily basis. Thank you very much.